Well, good afternoon, everyone. We're excited that you're here. I think most folks have joined us now. Welcome to the Dissemination and Implementation Launchpad's Implementation Science Seminar Series. I'm Shelley Ellis. I'm the director of the Launchpad and a professor in the Division of Hematology, Oncology, and Palliative Care. Um, we hope that if you're here today, that you might consider coming back. We meet the second Friday of every month at noon, and so this has been a great series so far this year, and we are looking forward to continuing it. Um, if you're at all interested and you're new to the group, this course is actually available for credit in the graduate program and in the Department of Population Health. And it's also part of the Implementation Science and Community Health Outcomes Certificate Program. So if that's something you're interested in, I'd be happy to tell you more information about that. Today, we are super fortunate to have Dr. Jay Ford, who's an associate professor here in the University of Wisconsin in the School of Pharmacy, where he serves as the co-director of the Wisconsin Opioid Overdose Response Center. He has training as a health systems engineer, and his research expertise is in the field of dissemination and implementation science. Over the past 20 years, he's conducted research in his lab that applies D&I science to address critical process issues in behavioral health, long-term care, and community pharmacies related to access to services. His research focuses on conducting organizational dissemination, implementation, and sustainability research using mixed methods to expand the use and adoption of evidence-based practices to improve patient outcomes and quality of care. His approach to implementation science involves reimagining healthcare through re-engineering and implementation science by integrating health systems engineering principles, quality improvement techniques, and practical experiences to develop organization-centric research that promotes strong stakeholder and participant engagement. Dr. Ford was part of a team of UW researchers who established the Network for the Improvement of Addiction Treatment, which I'm sure he'll tell us about, and taught substance abuse providers to apply quality improvement to improve access to and retention in treatment. So I am so excited that he's here to talk to us today about different implementation strategies, facilitation and coaching, among others. And so I'll turn it over to him to hear what he has to say. Thanks, Jay.
Great. Thank you, Shelley, for the gracious introduction and welcome to everybody. So we're going to talk today a little bit about facilitation, coaching, mentoring, and champions as it relates to implementation science. Just to start off, I don't have any disclosures. A lot of this research over the years has been supported by multiple projects. So just wanted to share that. Before I launch into this, I just wanted to take a minute to kind of dedicate this presentation to two folks. One, Dave Gustafson, who was my PhD faculty advisor, and I had a wonderful opportunity to learn from him, over the years, and be a part of the team, as Shelley mentioned, that established NIATx. And the other is Dr. Brian Garner, who is a friend and colleague, who was really way ahead of his time, in my opinion, in his efforts to design and implement innovative D&I studies that were not afraid to push the boundaries. So both of them will be sorely missed in the field. Whoops, let me go back. Come on, there we go. So I wanted to start off by kind of setting the stage a little bit, and let's talk about a few definitions. First of all, let's talk about the champion. So a champion is often the person that's identified as the face of the implementation effort in an organization. And they're the ones who are going to be dedicating their time and effort to overcome resistance or indifference while supporting the implementation of the thing, in the organization. A change leader, which in many cases is also synonymous with this idea of a champion, is the individual from NIATx. This is our experience from NIATx, is that's chosen by leadership to direct the day-to-day operations of the change efforts, including managing the team, keeping leadership appraised of how things are going. And then there's also this idea of a change manager, who's an individual that's responsible for planning, developing, leading, evaluating, assessing, supporting, and sustaining change implementation. So, champion, change leader, change manager, they mean different things depending on how you're looking at it, but they're essentially the same person, in the organization who is basically in charge of leading change. So, what makes this person or persons effective in the organization? So, this is some work from Shea et al. That came out in 2021, where they were identifying some of the champion characteristics and activities. And I've highlighted the ones that I think are probably important about the person. The rest of their figure talks about some of the roles and responsibilities. But they're arguing that, the champion needs to have, beliefs. They need to understand and believe in the innovation or the thing that they're implementing. Recognizing its relative advantages, compatibility, complexity. And for those of you that are familiar with Rogers' diffusion of innovation, you'll recognize that the idea of relative advantage, compatibility are part of those five things that he talks about related to the diffusion of innovation. The champion has to be committed. They have to be willing to put the time, energy, and effort into their role. And so, and they've got to, in some ways, be willing to put their reputation at stake. Um, he's also arguing, they're also arguing in this article that the champion may need to have experience or self-efficacy. So, is not only maybe prior experience or either with the innovation or leading organizational change, but they also need to have the skills necessary to either promote the use of the innovation or probably more importantly, the skills that they need to actually act as a champion in the organization. So, what does some of this look like? Well, um, for NIATx, we identified the change leader. We talked about kind of their role. We talked about the importance of appointing the right person. So, this idea that the executive leadership of an organization appoints the person to be the change leader. And they need to make sure that they have the time, the positional hierarchy, um, and firsthand knowledge. And they also have kind of peer credibility and authority in the organization to help drive change. But we also identified a core set of skills and characteristics. They need to be organized. They need to be able to act independently while also delegating to other members of the change team. They need to be persistent. They need to be able to be persistently pursue the change efforts that are going on in the organization. They need to be innovative and curious. Really important, they need to be comfortable with data. They need to understand how to use data to inform the change that's being driven, and they need to be focused and optimistic because these are all attributes and skills that they have to embed in and encourage the members of the change team to have in order to move forward. So, in this article that recently came out, or came out 5 years ago, talking about what matters in terms of attributes, um, they talked about things like influence, the ability to shape opinions and behaviors. They talked about ownership, being deeply personally responsible for the change efforts. They talked about being present at the point of change, possessing an intimate knowledge of the people and the workflows. Persuasive, being able to present information in a compelling way to various audiences. They identified a term of grit, basically being able to address setbacks that may occur and then be empathetic, be able to elicit and validate the perspective of others, which is vitally important if you're working as part of a change team. And then there was another article that talked about the characteristics of a champion in quality improvement, and that here they listed 11 different characteristics. Things like communication, again, and persuasiveness, humility, the go ahead type of person and the risk taker, somebody who's dedicated, who's motivated, who has a vision, who can encourage learning, in the organization. So as I read through these different people, these different groups, looking at what they identified as qualities of a champion, some of the things started to stand out as being mentioned, two or three times across the different studies that I was looking at. And so those included things like persistence and persuasiveness and the ability to inspire and motivate people. It included that the champion needs to have an ownership of the efforts. They need to be accountable. They need to take responsibility. The one in the middle is talking about how do they address challenges that come up. So this idea of grit, of being able to mitigate challenging circumstances or troubleshoot issues that come up as part of the change efforts. They talked about perceived self-efficacy with the innovation and also persistence at the point of change. And then the importance of being empathetic and being able to influence people. Because at the end of the day, the champion, whether it's a champion, the change leader, the change manager, is the person who's leading the effort to drive change in the organization. And they're hopefully working together collaboratively with a team of people to make this happen. So that's the champion. Now let's switch our focus a little bit to the coach. And so when we think about coaching, facilitation, and mentoring, again, it's important to set the stage a little bit by defining what some of these terms are, right? So sometimes you'll see a coach, maybe they're called a teacher, they're called a coach, they're called a facilitator. And really, the contextual situation frames our understanding of this person's role. So for me, I'm a teacher. I'm the person who is involved in the education of students. A coach, we typically think about them as maybe somebody that's associated with sports, or they're a coach or they're coaching in a healthcare system is associated with shared expertise. For example, a physician coaching on the advancement of individual careers. Now, in the work that I've done in the past, you know, from a coach perspective, my role is more of I'm coaching in the healthcare system with behavioral health organizations, with other organizations, and that's associated with shared expertise, me trying to share my knowledge about how to drive change in the organization. There's mentoring. Mentoring often is a longer term relationship, which support is provided to advance an individual's career. So again, in my case, I'm mentoring graduate students. So, we have a long-term relationship where hopefully it's a mutually respectable relationship where I'm helping them, advance, their careers. And then in implementation science, we often have the terms coach, implementation advisor, facilitator, external facilitator are frequently used interchangeably within implementation research. But what we do know is that the coach is, a discrete and effective implementation strategy. And we'll talk about that in a little bit. So, what are some approaches for coaching? Well, one thing is to engage people in the organization, key stakeholders, change team or learners, to design, implement, and sustain new processes that are hopefully improve the delivery of their services. A coach might also employ multiple different strategies, site visits, monthly calls to help the change team and the champion, build their skills in applying evidence-based quality improvement tools and techniques. If I'm doing my job right as a coach, or if we're doing our job right as a coach, we should be tailoring the learning interchange to individual needs and goals. And then we also need to think about using active, versus passive learning approaches to develop skills and confidence. This comes, this ability to do this effectively comes over time. But for me, the thing that's most important in my career has been I'm there to help the organization, the individuals learn. I bring a certain set of expertise to the table. But because I'm not a clinician, I don't practice in a behavioral health organization. I don't practice routinely in long-term care. I have to acknowledge that the people I'm working with have an inherent amount of expertise that I need to understand in order for me to effectively work with them. So in the past, we've used a couple of different approaches, for coaching. And these are coming from NIATx primarily, right? So one is this idea of a learning session. A learning session, a learning collaborative, whatever you want to call it, is often a one-to-many teaching relationship, where the interaction between the coach and the learner, um, and there's also opportunities for learner to learner teaching opportunities. These learning sessions often involve didactic and experiential learning opportunities where the individual learners are processing, the acquisition of knowledge that is impacted by the teaching style of the coach, their individual learning style, and how other learners leverage or use their individual learning style to teach their peers. And what this does is it helps promote, peer-to-peer sharing around implementation process, changes implemented, identify new ideas. One of the things that works really well if you're using learning sessions, and we did this in NIATx 200, and I'll talk about it, is create a roadmap, create a standardized roadmap of how the content is going to be delivered so that at the end of the day, if the learning session turns out to be the implementation strategy that is most effective, it was because of the learning session, not because of variations in how the content was delivered. Another type of peer-to-peer learning is what we call group coaching. And what that often involves is the coach is at the center and they're talking to multiple organizations at the same time to either share information, a new idea, for example, sustainability. But more importantly, these peer-to-peer calls really should be facilitated in such a way that the coach is eliciting feedback and commentary from the participants so that they can learn from each other. Again, we found that that is one of the more critical approaches when you're thinking about coaching. The last one of these is this idea of one-to-one coaching. So that's where, as a coach, I'm working with a particular organization. I'm working with the champion and sometimes the change team. And there we're focusing on, things like intervention, implementation. We're discussing the change projects. We're focusing on successes as well as barriers. We're reviewing implementation data. Remember, I said the coach and the change leader for sure, and the coach should be comfortable using data. We can look to identify opportunities for improvement and discuss ideas for future change projects. So, does any of this really work? does coaching matter and does it work? The answer simply is yes. It is one of the more commonly used implementation strategies that you'll see over and over again. And this research it's been 13 years ago, but by Blasterville et al., is still valid, where they did a systematic meta-analysis of facilitation in primary care physician practices. And at the end of the day, they found that primary care practices were 2.76 times more likely to adopt an evidence-based practice when guided by the facilitator. So, what this article also shows, which is interesting, that hasn't been explored, I don't think, enough, is this idea of how many sites can a facilitator work with effectively. So you can see from this chart, it's saying that as the number of practices that a facilitator is working with, the effect size or the effectiveness of their work, decreases. And I've seen that, when I work with organizations or when I'm conducting a study that involves coaching, I try not to assign a coach to more than about 4 to 6 organizations. Because after that, it becomes harder for them to be effective because they're working with so many different groups. And this next slide, talks a little bit about the facilitation efforts. And again, I think one of the takeaways is, um, they found that as intensity increases, so does the effect size, but little is gained by like longer intensity. So that basically means, the amount of time that you're dedicating, you're not gaining a lot, based on the number of hours that you're spending with folks. And they're saying that here they found that people who spent less than the time with less than the average number of practices were able to spend like 3 hours with the practice versus like a half an hour. And so there is a sweet spot in terms of how much time you can effectively spend with coaches, or coaches can spend with the organizations before kind of the intensity or the ability drops off. So let me take just a second to frame this um, idea of coaching and champions within Eric. And I'm doing that because I'm going to show you in a little bit why I think it's important to do this if you're using coaching and implementation research and when you're sharing out your findings. So, if you're familiar at all with the Go Zone chart that Byron Powell and his colleagues developed, this is what it looks like for facilitation and champion. And you can see, for the most part, strategies related to local technical assistance, ongoing consultation, identifying a champion, getting local opinion leaders involved, using an implementation advisor, they're all in quadrant one, a quadrant that is identified as having high importance and high feasibility. There's only one that falls in quadrant two, and that's using an implementation advisor, but you can see it's really, really close to being in quadrant one. And the same is true for providing local technical assistance. While it's in quadrant four, um, as being very important, it's really close to being in quadrant one in terms of feasibility. These are just the definitions from Byron and Waltz about these things. I'm not going to read them to you. They're in these manuscripts, but just so you understand what they mean. And you'll see in a minute when I dive a little bit deeper, what I think is really important is that if you're using these implementation strategies, you need to define them within the context of your research. So now I'm going to spend, and share some of the slides and some of the work from NIATx and from some other projects, just as it relates to coaching. So here's some early NIATx studies. So, first of all, NIATx, as Shelley mentioned, is the Network for the Improvement of Addiction Treatment. It was a partnership between the Robert Wood Johnson Foundation and the Center for Substance Abuse Treatment. What we did, under Dave's leadership was to create an easy to use process improvement model designed specifically for behavioral health to remove barriers to treatment and recovery. And then you can see here that providers, clinics participated in a quality improvement collaborative with these components. So early on, we did some work. We worked with Dr. Dennis McCarty and his team at Oregon Health Sciences University. They were the evaluators. And you can see just exposure to a combination of learning sessions, coaching, what we called interest circles, which is now kind of this idea of the peer-to-peer group coaching. We saw a significant reduction in wait time, a half a day per month over a 15-month period. These changes were sustained over the next 20 months. And then we saw a significant improvement from the first to the second and the first to the third treatment sessions. So, in terms of the number of clients that were actually engaging in treatment sessions, and that increased, by between 12 to 18%. So, when they started, people, maybe 50 to 60% of clients were coming back to from the first to the second, or the first to the third treatment session. And then we were up in some ways in the 70s and 90s, just by exposure to NIATx. And then these changes were sustained over the next 20 months as well. When we moved to NIATx 200 several years later, it was the largest quality improvement randomized controlled trial at the time. It involved 201 providers in 5 states. We were focused on wait time, retention, and admission. We had 4 interventions that sites were randomized to: interest circles only, learning session, coaching, or a combination. There was a project website, and there were a series of evidence-based practices for each outcome. I want to emphasize, as I mentioned earlier, we had a roadmap working with Dr. Andrew Kronbach and Alice Pulvermacher, as well as the rest of our team. We created a roadmap for how these learning sessions were going to be delivered, what was going to be the structure of these interest circle calls and the coaches. And our learning sessions were delivered by the same 3 faculty every time. The interest circle calls were facilitated by the same coaches every time. And the coaches met on a routine basis to discuss issues that we were encountering. And that's important because then we can start to see what results really mattered. And from this study, we can see that, learning session, coaching, and the combination resulted in significant improvements in wait time over 14 months. None of the interventions changed retention, and only coaching and the combination arm resulted in a significant increase in the number of admissions. But at the end of the day, we found that coaching was the most cost-effective strategy for driving improvements in waiting time and admissions to treatment. It was also most cost-effective for retention, even though there was no significant findings associated with that. One other early project, again with Dennis and his team, was what was called the Medication Research Partnership. The intervention was a combination now of learning sessions and one-on-one coaching. And we were looking at the percentage of members. This was conducted in part with Aetna, the percentage of members with a medication for opioid or alcohol use disorders. And we utilized a difference in difference in a qualitative analysis to determine barriers and strengths. So again, did the intervention matter? Well, not so much for patients with an alcohol use disorder, even though we saw changes. But we did see significant improvements for sites exposed to the intervention, the learning sessions and the coaches. These are the medication research partnership sites compared to the comparison sites. By the time we got to year 2 and year 3, in terms of the percent of patients, who actually were getting an opioid medication. So again, evidence that the coaching matters, the learning session combination matters in behavioral health. We then kind of took that and tried to, working with my colleague, Dr. Mark McGovern, we were using NIATx strategies to implement integrated services in routine care, trying to improve co-occurring capacity and medication access, working with our partners in the state of Washington. That resulted in a lot of different publications, which are here, just so you can see them. But let's dissect a little bit about what happened in this project. These were the goals. Goal was to determine if NIATx strategies are effective in implementing integrative services for persons with co-occurring substance use and mental health disorders. We had 3 aims, relative to the wait list, see if NIATx strategies improved implementation outcomes. Relative to the wait list, determine if NIATx strategies improve patient care outcomes. And then across the entire sample to evaluate variation in the fidelity to NIATx strategies. So in aim 1, we were looking at changes in dual diagnosis capacity as measured by the DDCAT. Aim 2 was really looking at the percent of clients accessing medications and the wait time to access a medication. And we got our data for aim 2 from the state of Washington, their administrative claims data, and aim 1 came from self-reported data by the participating clinics. This was roughly our design. It was a waitlist control design, and so you can kind of see the strategies of when people got stuff and entering a sustainability phase. So we had these 2 cohorts. This was spread out over kind of a 2-year period. I mentioned earlier the importance of identifying the strategies. So this is in one of the manuscripts that we did where we took the ERIC framework and we clearly articulated the strategies that we used, excuse me, and defined what they meant. So, again, I think my opinion is doing this helps inform the field about if I'm using a learning collaborative or if I'm using implementation advisors, exactly what does that mean? If you think back about what I think Enola Proctor talks about, it's like naming the actors, identifying what's involved in the strategy, because then I understand it. So again, just putting this in the context of the go zone chart, you can see that a lot of our strategies, fell in quadrants 1 and 2. We had a few that were in quadrant 3 and 4, but this is kind of where our strategies fell, for this DDCAT study. So did it matter? Well, the answer is yes. We did see some improvement. So for example, these are just examples of some of the results. So for cohort 2, during the active intervention period, the use of NIATx strategies significantly improved overall co-occurring capacity. So essentially, after working with their coach and participating in a couple of learning sessions, we were seeing that agencies in cohort 2 improved their overall co-occurring capacity. These same agencies showed a significant improvement in client access to addiction medications, and also the percentage of clients who got access to an addiction and a psychotropic medication increased significantly over time. And that's important because if you remember, the focus of this research was around improving co-occurring capacity. Wait time in cohort 1, we saw a significant reduction in addiction and psychotropic medication wait time from 36 to 29 days. Now, that doesn't sound like a lot. It's certainly not same day access to medication, but still we were seeing an improvement. But we also looked at kind of same day access or next day medication. So did they get their medication the same day or within 24 hours? And we saw that for cohort one, this significantly improved from like zero point 0.7 to 18% for people who are getting addiction and psychotropic medications. So it's both of these results around wait time are targeting the audience that we wanted to target with this work, which is individuals with co-occurring capacity. And they provide evidence, that coaching and learning sessions can make a difference. One more study to share that we don't really have, we're still working on our results, is the SITMAT initiative. It's another project with Dr. Mark McGovern in the state of Washington. Here we're trying to improve access to MOUD, and we started off in specialty addiction treatment clinics, but we're also working with primary care clinics. We had three aims. We wanted to evaluate the relative impact of a sequence of implementation strategies, and I'll talk about that in just a minute. We wanted to look at the contextual moderators and mediators, and then we also wanted to document cost. So this is our framework a little bit. We were looking at system, organizational, and individual level contextual determinants. We essentially had four strategies: enhanced monitoring and feedback, a NIATx MAT Academy, where we worked with the clinics to provide them training around NIATx and training and information around medication-assisted treatment. And then the clinics also had an opportunity to get internal facilitation or external facilitation. And these things were feeding into our implementation targets of reach, adoption, and implementation quality. And we were also looking at the effectiveness of the intervention as well as maintenance and sustainment. So what's unique about this project is it really is a stage-wise implementation to target. So what happened is everybody was initially exposed to getting a performance dashboard, audit and feedback. And then after that, as we designed it, if they didn't need any more help, they would enter a sustainment period, or they would move forward to this 2-day workshop, which they would learn, and then they would use the knowledge for the next 6 months to implement changes. Again, theoretically, as we proposed it, if they sustained their changes or improved, they would enter the sustainment period, and then they would be randomized to either internal facilitation, which was a curriculum that I developed with my colleague Matt Russa that was built around some of the NIATx change leader academies to basically train internal champions, internal facilitators to drive change from within the organization, or they were randomized to an external coach. And then those that were received the internal facilitation at the end of 9 months, they got external facilitation. We were also collecting information using the stages of implementation completion and the coins to try to get information about the competency and implementation cost across these strategies. And then you can see over what our primary targets were and how we define reach, adoption and implementation, and what the goals were, and then our secondary outcomes. Now, I mentioned this is what we planned. What we found out was that a lot of sites really wanted the coaching at the end. So even if they didn't need to move on to the 2-day workshop, they were willing to do that because they wanted to get to the place of getting the coaching. So, what we thought was a good strategy, real world implementation, very different. But as I mentioned before, here's the importance of naming what you're doing. So in our grant application, and then we further hone this in some of our when we publish the study protocol, we're identifying what each of these things are. So we're defining what each of the strategies are. That's vitally important. And then when you're actually reporting out, going back to the ERIC framework, like we did for the DDCAT study, and identifying, what you're actually doing provides a great roadmap to other implementation researchers to understand your study more effectively. I would challenge you, if you're doing this type of work, to really think about using ERIC, identify the strategies you use, define what they meant in the context of your study, because that just helps people understand things so much better. There are some other studies related to coaching that I didn't really have time to dive into, but one of the couple of the things that we did was this article at the bottom. I took the Grasha Reichman student learning style and teaching style survey and inventory, respectively, and adapted it to figure out uh, teaching and learning styles in a quality improvement collaborative. So what are the teaching or the facilitation styles that a coach is using, and what are the learning styles for folks in that? Oops, sorry. I want to go back. We use that in this study up here with the SAT to HIV to kind of as a qualitative interview guide to try to understand the coaching styles that were being used in this study. And then in a totally separate study in nursing homes, the coaches were taking notes, and we did a qualitative analysis of those notes to conduct a work system evaluation of the implementation of a UTI toolkit in nursing homes, looking at the difference between work as imagined and work as done. So there's a lot of work that can go into understanding coaching. And if you're using that, I would really encourage you to think about that going forward. With that, I'm going to stop, take questions, hopefully have answers to your questions. And this is contact information for later if you need it. So I'll stop sharing now and see what questions there are.
Wonderful. Thank you, Jay. I learned so much, and it's an amazing body of work that you all have put together just on this implementation strategy. And I see people cheering in the gallery too.
Yeah.
One question that came up in the chat, and I think is an interesting this. I thought about this when I was just learning about the idea of champions. But what's the difference between a champion and an opinion leader?
That's a good question. So I think it's even more important to also distinguish between formal opinion leaders and informal opinion leaders. So a champion is often the person that maybe is appointed to that leadership role. But when you think about an opinion leader, they're a person in the organization who you might want on the change team because they're the folks that people look up to, in the organization to kind of inform change. They're folks that you know, somebody's like, oh, I've talked to Shelley about this. I really value her opinion. I'm going to kind of go with that. But the difference between a formal and an informal opinion leader is it's odd in a way in that informal opinion leader oftentimes is the one who has more influence around the change. For those of you that are old enough to remember the E.F. Hutton insurance commercials, there's always people are talking about stuff, and then the actor representing E.F. Hutton, when they start talking, everybody stops because the idea is if E.F. Hutton is talking, we should be listening. That's what the informal opinion leader is. They're the person that everybody really listens to. And so one of the challenges as a coach can be identifying those opinion leaders and those informal opinion leaders, especially the informal ones, because they're the ones who can torpedo your efforts easily. If they don't like it, all they got to do is say, wow, that's a lousy idea. And if they say it enough, other people are going to go, wow, that's a lousy idea. So I hope that answers that question. So,
Yeah. And I'll take the time to just encourage folks if you have questions in the audience, please come off mute or feel free to type them into the chat. We had a couple of while people are doing that, you can also raise your hand if you don't feel comfortable just speaking out. Um, some of the students had been discussing or thinking about the readings and had some questions as well. One of the things is, I wonder if you could talk more about like how you in your various studies found the champions. Like how did you figure out that these would be the good champions?
yeah. So when we started off with NIATx, one of the things that we did was we identified attributes that we wanted, and we tried to really encourage the executive sponsor, at the organization, to identify who that person is. They often ended up being, maybe a clinical director, a clinical supervisor, somebody who was familiar with the process that we wanted to implement. Um, Not everybody, is cut out to be, a change leader. And, not everybody is the right change leader for every project that you're implementing. So again, one of the things we found was that sometimes maybe I need Bob to be the change leader for this project. But when I switch to a project that involves, say, handoffs, within the organization, I need to involve Sally, because Sally is the better person to be the change leader for that. But you also need to be willing to say, you know, Jerry, I don't think you're the best person. We're going to try to, we value your opinion. We want to keep you engaged, but we're going to promote somebody else. Um, but going through some of the, I think looking at some of the attributes, figuring out how to identify those folks. One of the key things is they need to be respected by folks in the organization. If they're not, that's not going to work. So,
Mhm.
um,
Yeah, Ed has a question
yeah.
related about, and I don't know, Ed, you want to come off mute and talk about it, but asking you if you developed coaches along the way and how you did that.
Yeah, I was just wondering that, coaching, I believe, is a skill that can be developed. And I'm wondering, in the context of these studies, what you did from a skill development. And then also, coaches can learn from each other. I noticed that, oftentimes these collaboratives, the groups are learning from each other. But
Yeah.
to what extent did coaches interact with each other to learn and improve their processes?
Yeah, so that's a great question, Ed. I do know in NIATx 200 and NIATx is stretching my brain a little bit too far back, but we did provide training for the coaches. The coaches did meet routinely, having monthly coaching calls to share the challenges that they were facing, and stuff like that, so they could learn from each other. We did at one point, and we hosted several of these. We developed a coaching academy where we actually brought people to Madison to train people to be coaches, using NIATx as a method. I know we hosted about three of those. It was a way for us to build up our cadre of coaches, and some of the people we invited actually ended up being, people that were our most effective change leaders in NIATx. We invited them to those coaching academies to train them up on how to be a coach, train them on those skills. and then tried to get them out there to practice. But yeah, we did provide training for coaches. We did provide opportunities for coaches to share, um, their experiences, their challenges. And that, again, is a vitally and crucial part of the process.
That's very meta. You got to coach the coaches.
Yep.
Dr. Hirschhorn has added a question, and she's welcome to uh, ask it herself. But also, she's wondering about measuring fidelity of the coaching activity. Oh, there she is. Hi, Dr.
Sure.
Hirschhorn.
Hi, thanks. So this is really great, and especially the mentoring versus coaching. So the question I have is, how do you measure the fidelity of the coaching? So I've done a number of different approaches: direct observation, feedback from the coaches, self-report. So sorry if I missed that, but I think it would be really helpful just to hear what are some of the techniques you've been done, each of which has obviously some drawbacks as well as some advantages. Thanks.
Yeah. So some things that we've tried, to do is to, provide coaches with kind of a framework of what the expectations are. We've also tried to do things like providing the coaches with standardized, templates to, capture and record stuff about their interactions with the sites. And how are they interacting? What are some things they're talking to them about? I think one of a challenge with fidelity is that to some extent you have to adapt your coaching style to the needs of the people, right? You can't just go in there with a rote checklist and ask them all these questions and think that it's going to work because that may not be their style. They may want to tell you a story along the way. Those of you that are maybe on the call that are practicing physicians, you probably know exactly what I'm talking about. Your patients want to tell you a story before they answer your question. But the feedback, creating the feedback mechanisms and I think the standardized ability for coaches to report, is crucial, to do that. Um, Fidelity is still, I think, kind of a mixed bag. I don't know that I have a good answer for exactly how you do that. Know, it's easy to assess, fidelity to like motivational interviewing. I can record the conversations. I can use a checklist. Am I using the right MI type skills? I guess theoretically you could do that if you had the right checklist for coaches, but again, that's labor intensive. So hopefully that answered your question. So,
Anand has a question. Welcome to ask it yourself if you'd like to come on. But he was asking about do you have any tools or methods that we could borrow? Anand.
Hey, so I really enjoyed your presentation. I was kind of curious just because in the quality improvement world, some of the tools that people use may not have the structure or support to support reproducibility in the way that a lot of the implementation science tools might help foster with things like the ERIC strategies and the specifications that. So I was kind of curious in some of the quality improvement work that you did and in the context of some of this, if you adjusted or adapted any of these tools to support that greater reproducibility.
um, I think, we did to an extent. I mean, in the work that I was doing with Brian Garner, he developed kind of a facilitator workbook, where we were using it to track our interactions with the sites and stuff like that. And I know we adapted that for, the DDCAT study, as again, more of a reporting tool, for the coaches. For the um, SITMAT initiative, we ended up, which I'm happy to have folks pull and, kind of the structure, we created a Qualtrics, survey for the coach to go in and enter information about their interactions and stuff like that. Part of what we did was try to populate it. So if I knew I was coaching, organizations A to D, I could just select that, from a pull down menu, and that way it was consistent. In the nursing home study, we did have a coach note template that we used, to modify that the coaches took notes on. So, we've done some of that. You know, are they 100% A plus perfect tools? No. Do they meet the needs of our study at the time? Yeah, they did. But I'm happy to share some of these things with folks, if they want to use them to adapt and modify. I think that's how the field grows is, you know, share ideas. And if you've got a better way to put the barn together, go for it. I could, that's not the analogy I'm looking for, but you know what I'm saying. If you've got a better way to build a better mousetrap, then, all for it. So.
Yeah. Jay, I'm wondering if you incentivize the coaches, like how did you get them to do this work? Because it sounds like they, had a lot of work to do. Were they paid? Were they somehow
Yes.
incentivized or just doing? Okay.
Yeah, we typically in our studies, Shelley, we typically budgeted for money to compensate the coaches for their time. Did we underpay them for the work they did? Yes. But NIH doesn't give you enough, money, to pay them, and especially when, they cut budgets, you have to make adjustments. But yes, we did at least those folks who served as coaches, external to the university, we did compensate them for their time. If there were somebody like myself or Mark Zahner, who I noticed was on the call earlier, if they were providing that service, then we tried to cover them, cover a proportion of their salary so they could have the dedicated time to do the work.
Great. Well,
Um,
thank you, Jay. This has been fantastic, and I know we've had great, robust discussion. I'm excited about that, and people learned a lot. With your permission, will share materials from the session today, and I'd like to invite folks back next month, the second Friday of April, and we'll be having Ed Vascolascas will be presenting, and so we'll have another robust discussion about some of the methodological aspects of implementation science. Please fill out our evaluation survey. We use that to continue this effort and get support to do that. So it always helps us if you can tell us what you think, and please suggest additional topics for, we'll soon be planning our next year's series. So we look forward to hearing from you what would be useful to you. So again, thank you, Jay. I know everyone really enjoyed this session.